So clinical implications of your renal physiology functions. So as we saw, the kidney plays a very vital role in your fluid balance, electrolyte regulation, waste excretion and acid-base homeostasis. So any dysfunction in your fluid balance can result in hypervolemia, hypovolemia. Electrolyte regulations can be devastating, like especially in terms of hyperkalemia and hypokalemia. Waste excretions, we all know, if kidney is not being able to excrete waste, then you will have toxic metabolites accumulating, which can cause uremic encephalopathy, uremic pericarditis, and then you have increased creatinine, which accumulates, which is responsible for acidic environment and can cause imbalance and severe refractory metabolic acidosis. So this is how we imply it in our regular practices. The first most important is acute kidney injury. So acute kidney injury can occur with even a minor insult of hypotension or electrolyte imbalance or your nephrotoxic agents. As we saw, the acute kidney injury, the validated criterion to diagnose an AKI is your urine output. So fall in your urine output to less than 0.5 ml per kg per hour for more than 12 to 24 hours is a signal for your staging of AKI. And in addition to it, there is also doubling of your serum creatinine. And this AKI has been termed into three types: pre-renal, intrarenal and post-renal. So pre-renal AKI, we saw there is an increased fractional excretion of sodium, wherein your 1:to creatinine ratio is often more than 20:1. So this implies that the pre-renal AKI is mostly secondary to your dehydration, hypotension, heart failure, or catabolic states, or loss of GI bleeds, steroids, azotemia, sepsis. All of these form a clinical impact as a pre-renal AKI. When it comes to intrarenal AKI, it is mostly renal ischemia, acute tubular necrosis, or interstitial nephritis secondary to lot of nephrotoxins which we use, aminoglycosides, or NaCIDs, or a simple pantoprazole which is responsible for interstitial nephritis, or amphotericin B, and all vancomycin. Lot of every drug which we use can have some of the small amount of nephrotoxicity. Then the post-renal, as we discussed, coming from the renal ureter, renal pelvis to ureter to the urinary bladder, any stones present, calculi, or any tumor infiltration, nodal obstruction, ureteral obstruction, or lower urinary tract symptom obstruction can all cause a post-renal AKI. Symptoms, we know, decrease in your fall in your urine output to less than 0.5 ml to almost anuria for 12 hours. Then once there is a fall in the urine output, you definitely have fluid retention which causes pedal edema, presacral edema, the increase in your blood pressure and as well as pulmonary edema. Then you have lot of electrolyte imbalance, especially your hypokalemias, and then refractory metabolic acidosis. And once your urea starts building up, you have uremic symptoms like uremic confusion, uremic pericarditis, nausea, vomiting and other things. So once your AKI sets in, your dyselectrolytemia sets in, hyperkalemia, hypokalemia, prone to cause erythemias. As your fluid overload builds up, your pulmonary edema resulting in respiratory distress. To an extent that patient might require even intubation and mechanical ventilation to reduce his work of breathing. And then as the fluid overload becomes very high, you can even have increase in intra-abdominal pressures, increase in intracranial pressures, increase in all the compartment pressures resulting in your multi-organ dysfunction. Management of your AKI, definitely treat the underlying cause. If it is a pre-renal, hydrate, remove the offending agents, remove all the nephrotoxic agents, prevention of hypotension, early use of inotropes, and then if at all required, renal replacement therapy if your kidney fails to pass your diuretic challenge test.